worst case scenarios. At the outset, we'll have, first of all, a good guest faculty from outside India, Dr. Toshika Ohta, who will talk to us on his technique of glued intraocular lenses or intrascleral haptic fixation. Are you ready? Dr. Ohta?
I'm sorry. Okay. No problem. So, okay. Doesn't work.
Are we ready, sir?
So,
AB?
I'm sorry, it doesn't work.
Takes
just
time?
Wait, just. So next please. So
go next.
Next
Can
please.
you put my computer on? Okay. Can I have it on the, yeah, okay, fair enough. So, ladies and gentlemen, let's see what we can do in this 85 minutes which we have. So the first case which I thought I will show you is a patient in which we started to operate, and you'll see this is titled as the correct shake for a handshake. Now you see here the patient has got a subluxated cataract. I'm doing a superior temporal clear corneal incision. I'm having slight difficulty in the rhexis. So far so good. Now I've been able to complete my rhexis. So I say I go ahead with my hydrodissection, and you can notice the nucleus is already out. Once my nucleus is out, I can go ahead and do a supracapsular phaco, but you notice here there is a massive subluxation already started. Now the mistake which I have done here is I should have put in a endocapsular ring at that stage, which I did not do. It would have stabilized the bag for me, or used capsular retractors. Both I did not do, but either way now I've been able to complete my phacoemulsification of the nucleus. But the problem is quite bad, because I realize it's a pseudo-exfoliated type of cataract. So what I'm going to do now is I'm going to just shift to a glued IOL. But now the problem which I'm trying to show you here is I've got a superior temporal incision. Now watch here carefully. You will notice this is 11 millimeters. And always go for the shortest distance available. In other words, horizontally I am 12 millimeters. Vertically I am 11 millimeters. And this trick was taught to me by Jeevan Ladi from Pune. So I'm going to make my scleral flaps now 12 o'clock and 6 o'clock. Always, when you have a rent, have fluid in the eye. Don't play this game with viscoelastic. The viscoelastic goes down. So always fix a trocar AC maintainer or a trocar cannula. A trocar AC maintainer, I'll show you in the next clipping, is even better than a trocar cannula. Now you can see I have rotated the patient. You noticed, and remember I was superior temporal. Now I have rotated the patient. So I'm making my flaps at 12 o'clock and 6 o'clock. Once I made my flaps, you can see two flaps being made. The first flap here. This is the way to make the flaps. Make 3 cuts. Then go from one end to the other, and just like you will do in your SICS incision, extend it out and you have your flap created. Okay, so far so good. I've got my flap created. Make my 22 gauge sclerotomy, and I repeat 22 gauge sclerotomy, just a millimeter behind the limbus. Don't go far back. Remember, these IOLs are all 3-piece IOLs are 13 millimeters. So if you go far back, the amount of haptic externalization will be less. So once I have done that, all I do is I'm going to knock off all this cortex and the capsule, because I can see the subluxation massive. This is the message which I'm trying to give you. If by chance your flaps are at 180 degrees temporally, you should be sitting temporally. Don't sit in the same axis, because if you are, you will never be able to do the handshake technique. And that's why I called it as the correct shake for a handshake technique. Now you can see I'm going to remove my cortex, and with the vitrectomy probe, I'm using the vitrectomy probe to remove the cortex, and at the same time doing vitrectomy and removing the subincisional area also comfortably there. So use a cutter and an aspiration alternatively depending on your comfort zone. If you're not very comfortable in the foot switch, you can ask your assistant to press the cutter wherever you want it. Now once I have done it, notice I have made a fresh incision now. I have made a fresh incision now, which will match me to do my glued IOL. Now once I have done that, notice, use any 3-piece IOL of your choice. Okay, you can use an Alcon lens, AMO lens, BNL, but the injector I advise people to use is an AMO injector because it gives a very good control. Now, once I have caught the haptic, remember, I'm catching the tip of the haptic, wait for the lens to unfold, catch it and pull it out. Now, once you have done that, look at the second hand. I've gone inside, gone in from the side port here, shifted to the second forceps. The first forceps goes back through the sclerotomy, catches the tip of the haptic, and I have now externalized that also. So this is the simple technique called the handshake technique. And you can see here how I have rotated my patient from a superior temporal position. Now I'm sitting temporally to do the correct shake for handshake. Create the Gabor-Charier's pocket with a 26 gauge needle. Tuck the haptics inside, and you can see amount of haptic tucked. You can tuck as much as the haptic allows you to tuck. So how much of a haptic is outside? Tuck the entire amount. And you can see once I have done that, do some vitrectomy, get your pupil back in shape, and you can see here once again I'm retucking that haptic to check its position properly. And once I have done that, I'll just make that pupil back to normal. So you can just stroke that iris. Now you can also inject some triamcinolone. Inject some triamcinolone because what it will do is basically help you see better if you have missed any vitreous present there. And you can see there, once I have done that, all I do is go in, clear off all of this stuff which is there, and you'll see how the case looks when it is complete. So this basic video we started off with to show you how to do the correct shake for a handshake. Do some stromal hydration, inject air. The reason I'm injecting air is I am going to apply glue, and for glue to come, I need the area to be dry. So remember, I've off the fluid, I'm now put in some air, I don't want any hypotony present, apply the glue there. Once my glue is there, you'll see I'll now seal everything down. And that's how the case looks when it's completed. Same glue I can use to seal the clear corneal incisions. Now, once I have shown you this, let's take this difficulty slightly higher. And what I thought was to show you a case, and this is something which you will see very often. Suhas, come on top. Now this, if you notice here, this is the new device which we have made from Mastel, and I was discussing with Suhas when he was asking me in the morning. This is 25 gauge, and this is a trocar AC maintainer. Now you can see here basically, this comes as a disposable set, and the advantage here is, if you see an AC maintainer, you have to make a knife incision, then pass an AC maintainer which is 20 gauge, whereas the trocar ACM is 25 gauge. Now what do you see here? You see basically an intraocular lens which is subluxated. But luckily, this is a 3-piece IOL which is subluxated. When I get a 3-piece IOL which is subluxated, life becomes very easy. So what I'm going to do is, again you notice I'm measuring. Always go for the shortest distance available. Here you can see, now you know this game very well. I'm making my 2 scleral flaps. Once I have made my scleral flaps, watch the trocar AC maintainer. Now I'm just 0.5 millimeter from the limbus. Okay? I'm going parallel to the limbus. Then I rotate. And now I'm perpendicular to the limbus. It's just like you would do in the retina surgery. Same way, once my trocar is inside, you can notice my cannula has come inside. I just pull out my trocar. Once that's there, I fix my fluid inside, and I have now fluid flowing in the eye. But remember, this is a self-locking mechanism of a trocar AC maintainer. Biggest advantage is fluid is always in the eye. Second big advantage is if I pull it out, I will not have any leak. I don't need to even suture it. Now, next step. I go in and I make my 22 gauge sclerotomy. Again, as I said, don't go very posterior. So about 1 millimeter behind the limbus, under the scleral flaps. Now, once you have done that, go in and do some vitrectomy, because you don't want to manipulate when there is vitreous present. Now, catch the haptic. It's already sinking. You want to be careful that this lens does not fall down and go south, because if it does, you will be in trouble. So what I'm going to do is catch the haptic. Once I have done that, I'm going to use 2 forceps. So they will work like a handshake technique, and that's what I'm trying to do right now. So here you can see now, I'm using 2 hands and extending my hands, means by the instrument become an extension of my hand till you catch the tip of the haptic. That is the game plan. Once I have caught my tip, I will now externalize that first haptic. Now I go in again, catch my second haptic. And again notice some assistant is holding an endoilluminator so that I can see better. Once I have done that, you can see the tip of the haptic grasped. Both haptics are out. Now I create my Gabor-Chariot's tunnel. Remember, check how much of haptic is externalized. I am saying 1 millimeter, go behind. Suppose by mistake you have gone 2 or slightly more and you see less haptic externalized. Very simple, don't have to worry. Make a fresh incision anterior to that. Put that haptic back into the vitreous and again take it out. Re-externalize it again from the anterior sclerotomy. So you need to have enough haptic externalized. You see both haptics have been tucked. Now look how the IOL is looking. Remember how the IOL was looking just before we started, and you can see how the IOL is looking now. Once you have done that, look what I'm going to do. I'm just going to pull out the trocar AC maintainer, and you can see there, once that trocar ACM has come out, I'm just going to seal it off there, and look, there is no leakage. Once it's not there, I injected some intraocular pilocarpine, make the pupil smaller. Now inject some air in the anterior chamber. Once the air is there, again I remember I told you the reason of the air is what? To prevent any hypotony postoperatively. Apply the glue. Now, question comes, how did this patient behave? So let's see how this patient behaved. Here you can see I'm just distending that eye. This is how the patient looks on table, and look at the patient post-operative day 2, and you can see a pre-op and a post-operative day 2 vision, and you can see the difference in it. Saying that, now let's move on to another case, and I thought let's make this difficulty even more. Now this particular case, when you will see, was an 80-year-old man. This patient comes to me with just one eye. This is the patient. He has got aphakia, but he's got bullous keratopathy. He's not totally blind. He will be about counting finger, but he's about 80 plus. Okay? And now let's see the other eye. This was the other eye. There is no perception of light, so other eye is gone. But this man was struggling because even that vision which he had, counting finger, was not good enough. So I thought, okay, let's see what I can do for him. And you can see now, I've taken him up for surgery here. And now first step in this is, I need to make him pseudophakic. So again, you know the steps now in this particular surgery here. Always have fluid in the eye. I've made my scleral flaps there. Once my scleral flaps are there, you will notice I'm now going to go in, do some vitrectomy there. Once I have cleared the vitreous, always check how the posterior segment is. So in such cases, I always check. Just put a contact lens and always do that with an endoilluminator. I'm checking because sometimes the previous surgeon might have dropped a nucleus or an IOL. Now whatever happens, once I've done that, I'm going to now catch my haptic. And you can see there, little bit of the haptic is a bit out. Catch that haptic. Once it is caught, I will externalize it. Now, if you have a patient like this, please dilate it with iris hooks. You'll be able to see externalization of the haptic extremely well. I have not done it because I'm quite comfortable, but I suggest to people to use iris hooks at this stage. Now you can see the second haptic getting externalized. Once both the haptics are out, now we know we are comfortable. I create my gauche areas pocket, tuck the haptics in, but remember, case not over yet. Because we have a bigger problem on our hand, and we'll do that for completion of this particular case. And remember, one-eyed man, other eye I showed you, he has no perception of light. This is the only seeing eye for him. And I had to be worried because an 80-year-old man coming to you with this question is either I leave him alone or can I make him better off and make his quality of life better. Here you can see I'm tucking the second haptic inside. Once that's done there, I'm taking off my trocar cannula, injecting air, sealing it with glue. Again, case not over. So now I'm going to see this patient post-operatively, how the patient is, and see, can I wait for a good cornea? Because this technique which we have started is called PDEC, and I have to give credit to Harminder Dua with whom we have collaborated on this. This is the same patient 1 week after the glued IOL, in which I was waiting for a good cornea, and to show the completion, you can see a trocar AC maintainer again being used, but in this case, I've got it inside to fix air in the eye. Now my next step is, I'm going to take off that bad epithelium. Once my epithelium is off, I will then take off this bad desmase, and I'm going to take the PDEC graft preparation. So in this particular case, what I'm going to do is, I've taken the cornea which we will take, and I'll show it to you just now, in which we'll be creating a bubble. In other words, a type 1 bubble. Here you can see now, this is 1 week after the glued IOL, don't forget. I'm taking off the final portions of that. This is the 19-year-old donor. I'm creating a type 1 bubble. Watch the bubble. It does not go to the periphery. That means this is a type 1 bubble. Where is the air? The air is between the endothelium, desmase, Dua's layer, air, then the stroma. If it went to the periphery, that would be a type 2 bubble. That means you'll get a DMEC graft. So once I've got a PDEC graft, I dissect this, load it into an injector, and just inject it inside. You can see I've also stained it with trypan blue. Now you notice how this patient will be. Here you can see I'm just going to load it into the injector there. Once it's loaded on the injector, I inject it inside. And once the graft is injected, I will use the endoilluminator to tell me which side is right and which side is wrong. Then I will unroll that graft, and again you can see my trocar ACM is still connected. So all I need to do is put on the air pump, and I will have air in the eye. So here you can see the air going inside that eye and the graft becoming centered. A PDEC graft, I can move it, unlike a DMEC graft. The PDEC graft I use at any donor age. The youngest I've used is a 9-month-old donor. Now the question comes, how did this patient behave? Okay, so let's see how this patient behaves. This is the same patient 2 months post-op after PDEC. And you can see here, pre-op, 1 week after glued IOL. And you can see now the final case, 7 months post-op after PDEC. So you can see this was, as I told you, a one-eyed patient. Now another thing which I thought I will try to show you people here is, this is a new technique which we have just started, and this is important for all of you to know. Simple, any anterior or even a retina surgeon should know how to do pupilloplasty. And this simple technique is called the single pass 4th row pupilloplasty. So let's look at it, because anyone in this hall should know how to do it and see how easy it is. You have a patient like that with dilated pupil. I'm passing a proline suture. Just take any proline suture, 9-0 or 10-0. I'm passing it through the clear cornea, catch one end of the iris, pass it throughout. Once it comes out, now watch, I catch the iris on the other side. Here on the other side, make a paracentesis. Take a 26 gauge needle through the paracentesis, through the iris. Now, through a railroad technique, bring the needle out. So far, so good. Now, all you need to do is single pass. Remember the word? Single pass. All I need to do is make one pass. Bring that loop out. That's it. That's a single pass technique. Now, I will make 4 throws. The cut end of this suture, 1 throw. You can see the second throw coming in, third throw coming in, and finally the 4th throw. Once you have got 4 throws completed, all you do is, you have got 1 suture on one end, 1 suture on the other end, pull, case, game, set, and match. So you can see there, take a scissor, cut the end of the sutures. Now you can do the same on the other side. So let's make this very simple. Single pass, 4 throw pupiloplasty. Now I've shown it to you on animation. Can I show this to you on real time pictures here? Traumatic, subluxated cataract. Patient has got mydriasis also because of traumatic mydriasis. Obviously, in these cases, I don't put endocapsular rings at all. I'm going to do a glued IOL. And you can see, I made a glued IOL done. Now watch the single pass, 4 throw pupiloplasty. I'm catching the iris. Remember the animation. I now pass the suture out. Come out through the other side. A 26 gauge needle on the other side. Railroad technique, as you can see. Come out. Once it is out, now I'll take this single pass. You can see, bring the loop out. Once I've got the loop out, I put 4 throws. Once it's done, pull both ends and look, my pupil is becoming smaller. Same thing now, you can do on the other end. Catch, pass it in. Once you have done that, do it from the other side. And remember, don't play this game with viscoelastic. Use fluid in the eye. You're very safe if you have fluid in the eye. So once I have done that, you'll see the other side also closed. Now you see the pupil much better. Now all I need to do is make that pupil, pull it a little bit, and you can see the traumatic mydriasis become like a normal pupil, and you can see pre-op, and you can see the post-operative. And let's see one more optic capture case using this technique. Again, you can see I'm passing this proline suture from one end, catching it from the other end, passing the 26 gauge needle, and you'll remember this technique. It's also been published in the PubMed in a peer-reviewed journal. So you have that online also. Plus you have these videos on our YouTube or iTube. Bring it through a railroad technique. Always have fluid in the eye, I repeat. Catch that loop. Once you have one loop out as a single pass, now pass 4 throws. And once you have 4 throws, remember you can do it on both ends. So one on one side, one on the other side, and you make this very simple. Every time you go in to make a pass, because some people will do two techniques, you have a chance of damaging iris, you have chance of damaging endothelium. So don't do that. Here you can see, so simple this technique is. So I thought now, the last thing which I wanted to show you perhaps, and then I'll ask Dr. Athiya to talk, and we'll move on to, perhaps to make it a bit of jing-bang stuff. Let's look at this video. Okay, this was the scientific portion, but I think we should end it always with jing-bang stuff. Okay, so let's see this. This movie is titled Longest Day Part 13. You know, Iron Man 1, Iron Man 2. So it's just a nice name for me to cover up my bad surgery. Okay, patient comes like this. Looks pretty easy. There's a posterior polar element. I've not realized it. I just go in and use my iris hooks to dilate it, remove my nucleus. But at that time, I've got a dialysis present. Once I have got my dialysis present, I do not know what to do. So what I'm going to do now is, I've removed my nucleus, but there's a bit of cortex present. I have not noticed a dialysis. So at this stage, what I'm going to do now is, just inject an IOL. Now the mistake I've done is, this IOL should have been a 3-piece IOL. I have injected here a single piece foldable IOL. My idea is to create a scaffold so that I can knock off this cortex and this epinucleus a bit. But look what I've got now. I've got a large dialysis created, which I had not seen. Believe me, I'm a terrible surgeon. I've not realized that. I should be blind. So I now fix a trocar AC maintainer because I know I'm in trouble. I start my vitrectomy. I've got fluid in the eye. At this stage, my lens starts tilting. Now, I'm worried because if this lens tilts, it goes down. And I'm trying to fix now a trocar cannula so that I have more space to play around with. And my lens is already sinking inside. At this stage, I want to go in and grab that haptic. Gone. Gone. So you see now, I'm stuck. That whole IOL has gone. So I had a dialysis which I created. From there, I went into this mess of an IOL going down. Now I make my scleral flaps. I made a scleral tunnel incision because I know that IOL has to come out. I do my vitrectomy. Now you can see there's a bit of cortex over the IOL which is there. I'm removing that. Once that's done, I will now use my extrusion cannula assisted levitation. This has been published in the BGO by Dr. Ashwin. Bring the haptic out. Grab it with a globe stabilization rod. Now I'm going to just pull this haptic out. Once my haptic comes out, I've explanted this intraocular lens. So far, so good. Now I realize, look, my flaps, they are not 180 degrees apart. That's absurd. You know, after doing so many glue dials, I still make these basic mistakes. So I take my haptic, bring it out. Now I do my second one, but look at the bend which I have created in the optic haptic junction. That should not be there. And when I have done that and externalized it, I notice that optic haptic junction is distorted. So all I need to do is pull this IOL out. Now this is my second IOL out. So I'm now going in for my third intraocular lens. Now when I'm doing that, you'll notice I go in, catch my haptic, but look, my haptic which has been externalized, I've lost it. And on top of that, my second haptic has gone through the iris. So now I have to release it from the iris, and the fear now I have is if this haptic goes down, my lens again goes down because the first haptic is still out. So now I go in again, catch that haptic, pull it out. Once I've got my one haptic out, I'm much comfortable. Go in with the handshake technique, catch that haptic tip, bring that haptic out. Once both haptics are out, now I've done my scleral wound suturing. Now I create my Gabor-Chariot's pocket, tuck the haptics inside. Here you can see both haptics tucked, but case not over, because you see the little bit of hyphema which I have created. I'm going to clear up this blood. Now I inject triamcinolone, check my vitreous in the anterior chamber, clear it all off. If it is there anything in the vitreous, I would like to remove. But again, I want to make my pupil better. So I'm going to again go back to my single pass suture technique. But look, when I did that, I dislodged the haptic again. So again I go in, catch the haptic again, retuck it again, and again start suturing my pupil. So I go in back with my pupilloplasty technique, which I just taught you all. Single pass, remember, 4-throw pupilloplasty. Remember, do this with fluid and you'll always enjoy this surgery. But the moment you start doing pupilloplasty, many cases you'll start enjoying them. So simple trick which I've shown you now, using an endolimiter from outside there, I get visualization better. One, I can do as many pupilloplasties as I want, making the pupil as better as I would like it to do. Here you can see it making better. There's a small nick which I had made here. So I'm going to make that suture also all right. Once my pupilloplasty is all right, IOL is all right, now I inject air and seal everything down. Here you can see how the case looks post-operative day 1. And look at the same patient 1 month post-op. Vision is 20/20. Ladies and gentlemen, thank you very much. I wish I could say I did something right, but I did everything wrong in this case. The one person on the top, the Almighty, helps us every time and helps us save our skin. Thank you very much. Atya. I'll ask Dr. Atya to come and speak on her nightmare situations.
Thank you, AIOS, for inviting us. Okay, after that stormy lectures of Dr. Agarwal, I think I have to show my videos, which are going to be a little different. You can see here the suture is protruding. All of us sitting here at one point of time in our life must have done intrascleral fixation of the IOLs, and you can see the suture is given way because these are biodegradable, and you can see the lens dangling there. So I plan to do a vertical gluteal. You can see the iris is also not very healthy in this case. So I'm planning to do a gluteal. Dr. Agarwal told you extensively, before you do any gluteal surgeries, you have to measure the anterior horizontal corneal diameter. If it is more than the vertical diameter, because we have only overall 13 millimeter lenses as of right now, we cannot do a horizontal gluteal, so I shifted to a vertical gluteal. And he explained to you very well that in this case you have to sit temporally, so that's what I am doing. And here is the suture. So what do we have to do? First, we have to take out the suture which is actually protruding externally by cutting it. Because the pupil is small and visualization is not that good, I put 4 iris hooks, and you can see this is a plate haptic IOL which has been sutured long ago by maybe one of us only, because we did a lot of this scleral fixation. This is our own patient. Now he has come back to us after nearly about 15 years in which the lens is just dangling in the vitreous cavity. So a scleral incision is made. Iris hooks are put in the 4 corners to enlarge the pupil, and sclerotomy is done with a 21 gauge needle, and using the gluteal forceps and holding on to the optic of the IOL and see to it that it does not go down, because the sutures also have removed, but part of the suture is still in the, hanging on to the haptics. Now using the vitrector going through the main port, do a little bit of vitrectomy. If there are any additions to the IOL haptic and optic, you can relieve that, but do not leave the left hand. With holding with the left hand the IOL optic, I took a globe stabilization rod and also a gluteal forceps in the left hand. Holding it with the left hand, I use the rod to go through the haptic, and I'm trying to flip it so that I can remove it through the scleral incision which I'm enlarging as of right now. You can still see the suture there, which is still sitting there on the haptic, and using the 2-hand technique, you have to somehow flip the lens in such a way that you flip it and then bring it out of the eye without leaving it. So IOL is explanted out of the eye. Before that, Dr. Amar told you very clearly that you can see the upper left-hand corner, infusion of the fluid through the pars plana is done in this case. The IOL is now come. It is still has some sutures a bit attached to it. A little bit of vitrectomy once to remove those pigments, etc. And using a 3-piece IOL, you have learnt it so much with the previous teaching of Dr. Amar, that hold on to the optic is very important. Using a glued IOL, your tray should always have 2 glued IOL forceps. I have no financial interest in any of these instruments I'm talking about. Epsilon has got very good glued IOL forceps, but you have to have 2 of them. And before you actually embark onto the surgery, see that they open very well, because sometimes they get blocked, and inside the eye you will have the haptic either broken, or you would not have externalized the haptic, or you would have deformed the haptic. Handshake technique is a very good technique in which you actually hold the haptic through the side port incision on the left hand, and go with the right hand through the sclerotomy, and once again hold on to the optic tip only, because if you hold it anywhere else, you will, as you're coming out, the haptic would have deformed. Once you bring the other haptic on, you can ask your assistant to leave it, and if you do not have an assistant, there's a very good technique which I wish I can show you. You can take a part of the tubing of the IV fluids and suture it, pass it through this IOL haptic and leave it there. It will not go inside. If any vitreous or any iris pigment is there, do a little bit of vitrectomy, and using a 26 gauge needle, create the gauche chariots, intrascleral pockets or the intrascleral tunnels, and tuck the haptic inside. Once the haptic is stuck, your main wound is sutured. You can see your pupil is not good, because a lot of trauma must have happened in the first surgery. So this pupil will not come back to normal. You cannot leave the pupil dilated like this or deformed, because the patient will not look aesthetically good also. So pupilloplasty, Dr. Amar has taught you so much, how he is doing the 1 pass 4th row pupilloplasty. This is how the patient looked post-operative day 1. Now what I did was a vertical glued IOL, and here you can see the patient doing very well with 6/6 vision. I could not have done better than this without this glued IOL technique. I have to share my laptop with Dr. Amar, so that's why this problem. Now, when we are doing a glued IOL, you've already seen that sometimes the eyes are short. In this particular, eyes are long. In this particular case, this eye is very large, so horizontal diameter is actually more than the vertical diameter, and this is a subluxated lens. I think a Marfan syndrome, so we are doing a vertical glued IOL. I'm sitting temporarily, the flaps are created 180 degrees apart, which is a very, very important thing, that they have to be 180 degrees apart. Using any dissector, if you're familiar with your trabeculectomy flaps, you can create this flap very well. Do not make them very thin or do not make them very thick. They should be ideal in size. Half thickness is the best. This is an infusion cannula, pars plana. I don't think there's any problem. Even as an anterior segment surgeon now, I can go to pars plana. But I'll be a little careful. Side port incision is made on either side here. And I'm going to do a vitrectomy a little bit to clear the vitreous which is there, attached to the zonules, and then create a peripheral iridectomy. Why am I doing this? The overall IOL in this case is only 13 millimeters. Most of the companies are only making IOLs which are 13 millimeters. And this is a large eye, as I explained to you. Though I'm doing a glued IOL, since this eye is large, I will not have enough haptics externalized, which I can tuck into the intrascleral pockets. So when I'm going, normally if I'm going through inside the eye with a glued IOL forceps, I will see to it that I'm careful that I do not go through the iris. In this particular case, we created a peripheral iridectomy, and I'm passing the vitrectomy probe actually through the iridectomy which I've created peripherally, and doing a lensectomy in this case. Be careful when you're coming close to the iris. You can shift between the cutter and the aspirator, otherwise you'll end up cutting the iris in this peripheral area, so you'll be sitting and suturing it again. So using the cutter, I've done the lensectomy, and only now I'm going to make my incision to 2.8 or 8 millimeter, and using a 3-piece IOL, which is going through the injector, and my glued IOL forceps this time is going through the peripheral iridectomy. If you can see that, it is going through the peripheral iridectomy which you have created, because I want to bring the haptic as anterior as possible. I don't want to go posteriorly, because I will not have enough haptic to tuck in, and this IOL will not be centered later on. So this is what I've done, peripheral iridectomy, through which the IOL haptic is come. On the left-hand side, my assistant is holding it. If I do not have an assistant, as I told you, I will plug it in through an IV set, which I will cut into a small one, which maybe I can show you next time. Once again, the right-hand side, also using the handshake technique, is going through the peripheral iridectomy and externalizing the haptic. My assistant is still holding the first haptic. Once the second haptic comes out, you can ask your assistant to leave it. Enough haptic is now externalized. I can tuck them very nicely now into the intrascleral Charrier's pocket, created with a 26 gauge needle. To make it more comfortable, what I do is I take my Blurex and I stain the needle little bit, the 26 gauge needle, so that I do not miss actually the tunnel. Otherwise, it is very difficult to find the tunnel to tuck this haptic inside. When you are tucking the haptic, be careful. You have to hold the sclera very tightly with the left hand using a tooth forceps, and tuck them enough and see that the whole lens is nicely centered. If it's not centered, you can tuck and retuck both the haptics and see there is no captive iris, because you have gone through the peripheral iridectomy. That's what you are seeing me doing that. I'm pulling the iris on either side and seeing that there is no captive iris in this case. Otherwise, I'll have to suture the iris and make the pupil round, stromal hydration, put just one suture. And before we actually remove the infusion cannula, you have to put the air, because you don't want to have a hypotony immediately when you're removing the fluid. And using the fibrinogen thrombin combination, you can glue the flaps, not only the flaps, the conjunctiva, the incisions which you have created, and this is how the patient look post-operative, day 1, and the iridectomies are looking peripheral and very nice. Patient has got 20/20 vision. So that's how this patient looked post-operatively. I'll move on to my next presentation. Sorry. 1 second. Give me the sombering ring. Escape. 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 Sorry about that. What you see here actually is nothing. We call it a sombering ring. You must have seen a lot of time patients come with trauma with an absorbed lens, or patient has undergone a Fusaka surgery for myopia, in which you do a decision or something in the center and leave behind the capsule, the cortex and epinucleus, everything in the center. You just clear it because the vision should become clear. So now what happens to this is, these sombering ring form in the periphery, patient is left aphakic, and many of the times you can see that these patients come to us for glue dial because they do not have any lens implanted in the primary surgery. And you can see only when you dilate this, you can see this ring in the periphery, which is called a sombering ring. Now with this ring in the periphery, what I'm planning to do is, I'm going to do a glue dial, and later on I'm going to remove this ring because I cannot leave this, because of my manipulation it might get dislodged, and either it will come anteriorly and block the angle, or it might go posteriorly and it will be falling into the vitreous or on the retina. So first I'm doing actually a scaffold in which over this ring itself I'm doing my glue dial. Everything is the same. You can see the infusion cannula, they have gone to the pars plana. 180 degrees flaps are created using the glue dial forceps, using a 3-piece IOL. I have gone through and externalized one haptic, the second haptic using the handshake technique. All is the same. In this case also I have not gone too much posteriorly, because if you go too much posteriorly, as I said, you will not have much of the haptics to be tucked inside. So you should remain only anteriorly. Now once you finish doing the glue dial, you have to tackle this, even tuck the haptics so that you are safe when you are manipulating the sombering ring. So haptics are tucked into the intrascleral pockets, or the Chariot's tunnel, which we call, and you analyze how much of this white ring is present there in the periphery. Now to make my life much easier, because I want to visualize it better, I am putting iris hooks in one segment, in one half of the eye, and fixing 2-3 iris hooks, 3 or 4 iris hooks in one segment, and now using the cutter, but this is very dense. If it doesn't come through the cutter, then there is no problem. You go with the cutter, release all the adhesions which are there, the capsular adhesions to the iris or to the periphery. The 2 capsules are adhered there. Remove these adhesions and then dislodge the sombering ring. Bring it anteriorly. You have the IOL there, which is sitting in its place, and this is going to act as a temporary platform, or going to act as a scaffold. And I have taken my phaco because this is a very dense ring, and remove the sombering ring from one area. Do a little bit of vitrectomy once again in the periphery. Move on to the right side of the eye and use the same thing. Use 1 or 2 iris hooks. Dislodge the sombering ring. Bring it anteriorly. It is not going to go anywhere because the IOL is there and it is not let it go back. And using the phaco probe, I remove the sombering ring and check it once again. Go behind, do this exercise in the whole eye until you remove the entire white ring which is sitting there in the periphery, which cannot be left alone. You have to do a little bit of vitrectomy so that you relieve this adhesion, so that the rest of the lens matter becomes free and then comes anteriorly, and using the phaco probe, remove this meticulously from the entire eye. Take a rod and sweep the iris and see that the pupil becomes round. If it does not become round, then you know what to do. Do a pupilloplasty, taking the fibrinogen thrombin combination, using one by one, glued not only the flap, glue the conjunctiva. It comes in a 2 ml of fibrinogen and thrombin, so you can easily use about 4-5 cases. You can even keep the syringe inside the fridge for about 24 to 48 hours and do it the next day. The remaining glue I'm putting for all the paracentesis which are created for using the iris hooks, and check the patient's hypotony, the eye hypotony, and this is how the patient look post-operatively with a vision of 20/40. My next video I'm going to skip because I think Dr. Ota is going to show the L-shaped incision, which should not be a repetition. So thank you very much for your patient hearing.
Thank you very much, Dr. Atya. Well, ladies and gentlemen, just to tell you a little bit about Ota. Ota won in last year the ASCRS Film Festival, the first prize to show the L-shaped incision. And also he has brought out a lovely modification on the glued IOL, which is the Y fixation and the T fixation. Ota, over to you.
Okay, Amar, thank you. Good afternoon. And today I'd like to speak about powers of industrial fixation of positive IOLs. In patients with insufficient posterior capsule support after cataract surgery, 3 different intraocular lens implantation techniques have been used for optic rehabilitation. In recent years, Garbo first reported industrial IOL fixation methods that secure the haptic to the inner surface of the sclera rather than using intraocular suturing. And next, Agarwal reported a glued IOL technique using fibrin glue. And Dr. Amar Agarwal and Dr. Ati Agarwal are world-famous doctors and the greatest surgeons in the world. The advantages of the glued IOL technique are it is simple and easy, and there is no need to suture. However, to our regret, the use of fibrin glue is not approved in Japan. The advantage, and so we have also reported a new interscleral fixation method that does not use fibrin glue, called Y fixation technique. This technique is a subtype of glued IOL technique. Next, I devised a modified technique called T fixation technique. In T fixation technique, I create a T-shaped incision. This slide shows the differences between Y fixation technique and T fixation technique. With the T-shaped incision, we do not need to make a square flap, and the incision can be created easily. At this time, I'd like to show a video of this surgery being performed. This case is an aphakic eye, marking the location with a reference marker and T marker. Making the T-shaped incision with a feather knife. Performing an anterior vitrectomy. Making the sclerotomy. And making the screw tunnel. Penetrating the anterior chamber. And early insertion using an injector. And next, externalization of the leading haptic. And insertion of the trailing haptic into the antechamber using gasoline forceps. And externalization of the trailing haptic. And next, insertion of the trailing haptic into the skin tunnel. And the incision is sutured with 8-0 fiber to prevent leaking from the wound, and the haptic is embedded in the sclera. After the haptic is inserted into the sclera tunnel, the incision is sutured with 8-0 fiber to prevent leaking from the wound, and the haptic is embedded in the sclera. This slide shows the instruments for T fixation technique. By using these instruments, we can perform surgery easily and accurately. Here are the long-term postoperative results of the T fixation technique. Statistically, the corrected distance visual acuity improved significantly after surgery. This slide showed the postoperative complications. There were no cases of significant IOL decentration or severe complications such as macular edema, retinal detachment, and endophthalmitis. This slide shows the postoperative view of the antechamber. Stable fixation is confirmed without IOL decentration or tilt. Recently, a correlation between intraocular collaboration and IOL tilt has been reported. Intraocular collaboration in our T-fixation technique is also significantly less than with transcranial IOL fixation, showing virtually no difference from in the back fixation. The value of T-fixation technique is lower, approximately half that of transcranial IOL fixation. This slide shows a comparison of IOL tilt between good IOL technique and transcranial IOL fixation. In IOL tilt, the value of good IOL technique is lower, approximately half that of transcranial IOL fixation. The fixation technique advantages include anatomical stability, optical stability, no need to use spiral glue, does not require a suture fixation IOL, also applicable to IOL dislocations. Next, I'd like to speak about the flanged IOL fixation with double needle technique. Dr. Yamane, a Japanese ophthalmologist, presented a double needle technique. And then at ASRS and ASRS last year, he presented the new intraocular fixation technique called the flanged IOL fixation with double needle technique.
Haptic is inserted into the inner cavity of the 30-gauge needle. A second 30-gauge needle is inserted on the 180 degrees opposite side, and the trailing haptic is inserted in that needle's inner cavity. Along with the two 30-gauge needles, the haptics are taken out of the eye. Ophthalmic cautery is used to thermally deform the tips of the haptics and build a flange. The flange of the haptics are pushed inside the sclera to fix the haptics in place.
At an academic meeting held in Japan last year, a report was presented that compared postoperative IOL tilt between the T-fixation technique and the flanged IOL fixation technique. The average postoperative IOL tilt was 4.8 degrees using my T-fixation technique and 13.2 degrees using Dr. Yamane's flanged IOL fixation technique. In the flange technique, the tips of the haptics are burned and crushed and then replaced inside the eye. Therefore, the length of the haptic inside the eye is longer. The IOL optic is unstable, and the injection needles inserted into the intraocular sites are unstable. These factors can cause IOL decentration and IOL tilt. At an academic meeting held in Japan last month, another ophthalmologist presented the same result. The flange IOL fixation technique is a simple method. However, it is still a developing technique. Dr. Agarwal's glued IOL technique is generally thought to be the first-line method for intraocular fixation. I think that it is important to make the scleral incisions in the right place by using markers in order to prevent IOL decentration and IOL tilt. In intraocular fixation, we can use a standard 3-piece IOL. However, the selection of the IOL is important. This is one of my preferred IOLs. This IOL has a long total haptic length and a large optic diameter and is suited well for endoscopic fixation. These haptics are made with PVDF, which are difficult to transform when gripped by forceps. PMMA single-piece IOLs and acrylic single-piece IOLs are inappropriate for endoscopic fixation. Next, I will talk about a new IOL for endoscopic fixation. Generally, an IOL with a long total length is required for endoscopic fixation. The total length of conventional IOL is 13 millimeters. Currently, an IOL with a total length of 15 millimeters is available in Japan. Actually, this is an IOL for large dogs. You can see that the total length of the IOL for dogs is obviously longer than that of IOLs for humans. And Dr. Yoshida, a Japanese ophthalmologist, reported a new IOL for endoscopic fixation at AIOC 3 years ago. The total length of this IOL is 14.0 millimeters, and the diameter of the optic is 7.0 millimeters. The haptics are made of PVDF and are hook-shaped. Santen Corporation in Japan got a CE mark in Europe for the new IOL at the end of last year. Another Japanese corporation will be launching a new IOL for endoscopic fixation this year. Its total length is 13.5 millimeters.
With your left hand, insert the cannula through the scleral incision. Then pull the haptic and place it just under the iris. The rear haptic should be placed in the vicinity of the iris. After gripping the rear haptic with the right hand with either the cannula or forceps, use both hands to extrude both haptics.
The haptics can be easily gripped with forceps due to the hook shape. The tip of the haptic can also be easily inserted into the screw tunnel. It has been pointed out that when the trailing haptic is pulled out from the eye, the leading haptic may slip back into the eye. However, when an IOL with hook-shaped haptics is used, the leading haptic does not slip back into the eye during manipulation of the trailing haptic. This IOL has an additional advantage. The haptics are unlikely to slip out of the square tunnels because of their hook shape. This haptic, very easy to grip the haptic and very easy to extract the haptics, and very easy to externalize the haptic, trailing haptic, and insert the haptic into the screw tunnel. The haptic of this IOL can be pulled out of the eye by using hook. I developed this U-shaped hook. Using this U-shaped hook, the haptics can be pulled out easily without employing forceps. In the future, the hook technique may be established. Using this U-shaped hook, the haptics can be pulled out easily. In conclusion, as well as surgical techniques for intraocular fixation, and special IOLs for intraocular fixation have been developed. Therefore, I think that intraocular fixation procedures will make further progress in the future. Thank you very much for your attention.
Thank you very much, Dr. Ota. It's a pleasure for you coming all the way from Japan here to educate all of us in India. We want to thank you for that. And I also want to thank Lalit Verma, Ramurthy, the entire team of AIOS, and even Santan for inviting Dr. Ota here. Please join us. Well, the next person we have is someone whom I have such high regards for as an ophthalmologist, but more also as a great human being and as an educator. And we have none other than from Mumbai, Dr. Suhas Haldipurkar. And Suhas, let's hear what you can talk to us on your phaco nightmare situations.
Thank you, Amar. But the talk that's given to me is hard cataract and complications. Friends, you all by now must be in the space on a journey. It's my duty to bring you back on earth, because the ordinary mortals like us probably cannot do the kind of work at the level that Amar has perfected. And so obviously, don't be too disappointed if I take you through the day-to-day phaco complications. And of course, there are no financial interest. Now, this was one of those cases, and I have always over the years found this type of cataract as difficult one. From the moment you start doing your rexes, everything seems to be not okay. Especially in this case, I wasn't sure if it was a subluxated, because very often when the cortex gets liquefied, the nucleus tends to dislocate or sink on one side, although the capsular bag is intact. But this happened to be one of those cases, and I should have guessed it looking at the structure and the surface of the capsule that the bag was severely deficient in its zonular structure. So, the obvious next choice for any of us is to stabilize the bag before you take any step. And when you put an endocapsular ring, one has to remember, and obviously we remember, that the moment 3/4 of your ring is inside the bag, you get some kind of that spring action, and that tells you that your ring is properly going through the bag. And here, as the ring is in its last step, I miss that spring effect, and when it's completely in, I start seeing both the ends. And when you start seeing both the ends, that means something is definitely wrong. And when I leave, they normally spring back, and here they don't. And it tells me that either the capsular bag is torn, or I have missed the bag and gone behind. And then I realize that the capsule is torn, meaning there's no strength in the capsule. Of course, this is a very old case. Probably today, if I can tell you, that I would immediately do lens scaffolding and then maybe complete the phaco. But this was some 8 years back, and obviously I had to get the nucleus out and then just pull the capsular back. And by then the capsule had come down. And well, you go out to an easier way out, and not like Amar, where I thought I would be comfortable with retrofixated iris. This was, let's say, some 3 years back. one of those real hard ones. And I have always felt that if you want to balance between minimal utilization of energy and still get your nucleus emulsified, it indeed is a tough job. And I'm sure you would, relate to this when I tell you that sometimes when you think that zonular structure is not very healthy, I prefer, or so I thought, that I would go in for 4-quadrant and at least debulk the nucleus as much as I can. But at some stage, I get a feeling that, beyond this, I'm not really able to make any headway. And this was the nozzle that I was using. I thought, and plus I saw the bag not very strong. I thought maybe if I fix the bag, I would be able to do. But nothing seemed to be progressing the way normally a cataract progresses. Because when you don't have that kind of support from behind, because we say that in the phaco-dynamics, one of the part that we miss is also the support your capsule gives you. And at this stage, I see the capsule coming over it, meaning it's collapsing. One mistake I make at this stage is that this was the time to wait, stop and put the endocapsular ring in, stretch the capsular back. But sometimes when you're so much ruffled that some of the vital steps you miss, and then I obviously at some stage I give up because I realize that the capsule is severely deficient. Again, at this stage, it's debatable what procedure I could have gone by, but since after you do a long case, and then if you have to again go through glued IOL or scleral fixated, one, you have to have patience like Amar's, and number two, you should be really good at it. Here what I'm showing you is when you have a severely subluxated cataract, very often doing a rhexis is also tough. At that time, you sometimes need to support it with the second instrument. And then even after you have fixed the lens, capsular bag with the hooks, halfway through your phaco, you realize that your capsular rhexis is not big enough. So you can always stain it halfway through your phaco and continue with your rhexis, because unless your rhexis is big enough, you are further jeopardizing your chances of doing a proper phaco. And then, of course, even if you see such an extent of zonular deficiency, you can always put an endocapsulating and complete. And what I do here is, if you are in doubt, you can always put a suture on the trailing eyelet. So in case you miss out and the ring starts going down, you always have some kind of a helpline where you can just pull on the ring and get it out. At this stage, I take a call. I said, if the bag is not that good, I have two choices. One, fix it with a segment, or keep the bag there so the posterior segment is protected, and use a lens that you are comfortable with. This is a case of advanced cataract with extremely fibrous anterior capsule. When you have an anterior capsule like this, doing rhexis by itself is a tough job. Very often, you may have to use different instruments to complete your rhexis. And when you realize that even with the forceps, you cannot make a tear in it, sometimes you use scissors to make an opening. And then when even scissors is not really enough, you use your cutter, because you need a sufficient central opening to complete your rhexis. And when you have a cataract like this, which is grade 4, 5, 5 plus, and when you have done a rhexis of this kind, you're quite sure that rhexis is not going to be intact one, and halfway through your procedure, this rhexis is going to tear and it's going to go into the periphery. And when it goes into the periphery, there are very high chances that your nucleus will start sinking even before it's completely out. And at such times, the safe zone is anterior chamber, and in that, you can always rest your lens on the lower iris, of course, with dispersive viscoelastic, coating it from above. So what I do is kind of a supracapsular phaco, where it's not sitting on the capsular bag, but it's sitting on the iris, controlled phaco utilization, under dispersive viscoelastic, going a little slow about it, and you can certainly complete a phaco. The whole idea is, if your phaco tip is never outside the nucleus when the phaco energy is on, to a large extent, your endothelial damage can be avoided. But obviously, when you have an intact posterior capsule but incomplete rhexis, the obvious choice would be a 3-piece. So I go for a 3-piece lens in the sulcus, and it completes a case. This was another tough case which shows you sometimes halfway through you may have to take a call and use multiple instruments to go ahead with your case. It progresses as always properly. Being a small pupil, in those days I was using Maliogin's ring more commonly. Maliogin's really opens up the pupil well. Even the present ones, BHEX and other pupil expanders, open them. But you have to remember one thing. If at the end of the surgery you want the pupil to be circular and central, you have to be a little cautious with regards to stretch pupilloplasty. And now the situation that I realize is that after the rhexis is complete, the bag starts moving as the phaco progresses. Now your pupil is expanded with the ring, and your capsule is supported with your hooks. And I'm using the easy tip, which in my hard cataracts comes as a great rescue. You can work at very high energy, but because of high flow sleeves, your endothelium is always protected, and it works well. And now you have an intact bag. You insert an endocapsular ring, and at that stage you have to take a call if the bag is good enough with the endocapsular ring, or would you like to support it on one or two sides with a segment or a sionis. And the lens is in the bag, seems to be fine, and I close the case. And I thank you, Dr. Amar, for this opportunity to share some of my complications.
Thank you very much, Suhas. I think to show so many crazy cases is very challenging, and it just shows the surgical skill which you have. Salute you for that. Let's now hear it from the president of the Indian Intraocular Implant and Refractive Society, Gaurav Luthra, who's going to talk to us on his cases which are really worst case type of phaco nightmares. Gaurav, all yours.
Thanks, Dr. Amar, and it's really a privilege to be part of your course. I've learned so much from you, and then to be in your course after, so much to learn from you and then share with everyone. This is very good afternoon, everyone, and I wanted to share a couple of cases. I'm a bit in a rush because we are going to be out of time in 10 minutes, so please excuse me, but we'll see two videos where I thought I was challenged a lot. So this was a patient which was referred to me by one of my colleagues, and apparently the surgery was initiated and the rhexis was made, but as soon as the rhexis was attempted, before it could be completed, the pupil came down and the surgeon did not have access to any of the pupil devices, and so the surgery was aborted and referred to me. I was operating 2 days later. There was a big bubble and the pupil would not dilate bigger than this. So as we started off, so the visualization was not great, and the incision actually which had been made initially was a sclerocorneal kind of small incision here, and I made 2 fresh side port incisions. I had to actually explore and see what was the status. There was no idea that whether the rhexis was salvageable or not, and I made a clear corneal incision because I prefer to make it at a particular clock arc position which I enjoy. I did not want to play around with that original incision. I decided to stain the capsule to assess what was the status of the remaining capsule and whether we could fashion a rhexis out of that or not. So, and since you can see that the pupil was small, now I used viscoat to protect the cornea as well as to create a cushion there, and also maybe to do a bit of viscomydriasis, and that gives a good idea of where we are. So as you can see, the rhexis was almost totally messed up. There was pretty much, it was a broken capsule at several places, and I had to then also deal with a small pupil. Now, whenever there has been a capsular rhexis or a broken rhexis, I prefer not to use any of the pupil expansion rings, because sometimes they will just engage into the broken fragments of the capsule or the broken edge of the capsular rhexis and damage it and extend it further. So I prefer to use iris hooks in such situations because they are more controlled in such situations. Otherwise, of course, I also use a lot of the rings and the Bhattacharjie's ring and the Malugin's ring. Now here, once we were able to dilate, it was a hard cataract, so I had to make a choice about how to go about this. So the hooks gave me good exposure, and on assessment I realized that this was going to be tough, and I decided to convert this into a can opener kind of thing. I had mentally thought that I might just decide to go for an ECC or a similar, but then I decided that it was a good idea to probably see if I can get this nucleus out. It was a bit of a sticky cataract, and I tried to see if I can mobilize it. Since the pupil was very small and originally, and then the iris hooks were in place, so I thought if it's a softish cataract, it looked a little brown, but I thought it's worth attempting if I can, without much manipulation, if I can get this out. Now, take-home message should not be for those surgeons who are not doing high-volume phaco. I would suggest that this is not a great way to tackle such cases. A better way would be when you have a can opener to switch to a situation where you deliver the nucleus. But here I wanted to just fancy my chances and see if I can trench and somehow have 2 fragments. Then I can just rotate the fragments out of the bag and do a supracapsular phaco, and I was therefore trying to trench this and see if I can crack it at some point. Chopping was becoming difficult because it was more like a sticky kind of cataract, and the reason why I wasn't very happy to convert to an ECC was because of the situation with the small pupil. I would have had to remove all the hooks in that case, and then my visualization would go down, and then it could be a further mess in this case. So I was just being very gentle and trying to ease the fragments out. It was a very friable lens because of the reason that for 2 days it had been lying in aqueous, and it was the nature of the lens proteins changes completely when they've been exposed for a period to the aqueous. I was able to make some progress, and using a machine like I use a Centurion, which actually works really well because at low IOPs you don't have much pressure of the chamber is very nicely controlled, and you can actually work at very low pressures, so you are not over distending the bag, and the control goes up much more than you would have with another machine which has a high bottle height, or otherwise you'll have surge. So there is almost no surge here. I don't have any financial interest, but I enjoy using the Centurion. Especially it becomes very useful in such challenging cases where the fluidics become very important. And I was finally able to get this nucleus out, and then we had to deal with the situation of how to get the cortex out without breaking the PC, and then also how to put in a lens. So you can see that there was some upthrust, there was an iris prolapse, and now I love the Lumera for this because it gives you an amazing red glow, and you can see it almost switched on there as if somebody had switched on an endoilluminator or something. And then you can obviously tackle the cortex. You have to be very careful not to catch the tags. In retrospect, I felt that I would have been happier to convert this into some kind of a rhexis rather than do the can opener. In that one small instinct, I thought, there's no point proceeding with this and I'll just convert it to a can opener. But in retrospect, I felt that I should have probably gone and converted this to some kind of a continuous capsular rhexis. Even if it was broken at a couple of points, wouldn't have mattered. So that's another lesson which you can probably learn from what mistakes I made. Because with can opener, small tags, it's always more likely for you to catch hold of one tag and maybe pull on it with the aspiration handpiece, and then... Now you can see that I'm trying to be very, very controlled here because the cortex is also very sticky, and there's always... And I'm not switching off the infusion at any point till I inject the viscoelastic, because if there's any fluctuation in the chamber, I will end up... But as happens with Dr. Amar, and he shows every time the longest day, story was not over yet. And when I went in to put my lens, there was more waiting to happen. And I enlarged the incision from the 2.2 to about 2.6. And I'm trying to hold the iris down, as you can see with my manipulator from the left hand. It's a good idea to do that because sometimes it will just plug your the port of the injector, and then you'll have an iridodialysis. So you can see there was a sudden injection, and in that sudden injection, the lens suddenly turned upside down, and the haptic came out in the wrong way. So it was an uncontrolled injection, which I didn't like, and in such a situation, you definitely don't want an uncontrolled injection. And you can see that my lens is now flipped inside the bag, and the haptic, which was the leading haptic, it probably went and injured the iris somewhere. I'm so much more happy to use the single piece lenses, but in such situations, because you might have to put the lens in the sulcus, it's always a good idea to go with the multi-piece lenses. Now you can see that I've managed to flip the lens, but the haptic seems to have got stuck on the iris somewhere, and there's a bleed which has started to happen. So whenever such things happen, I start remembering the lessons learned from Dr. Amar, because he's shown us such brilliant surgeries which he's managed over the years. And you can see how bad the hyphema is coming out to be now, but somehow I think I'll manage that and put in the lens into the bag, whatever remnants are there. And I think we ended up with a fairly good outcome. We were able to manage this, and I put a suture because I wanted that to be secure. You can see that I'm hydrating the wounds with my infusion in so that there is no fluctuation in the chamber. It's a great idea to do that because you always get a controlled atmosphere. I have just one more case to share with you, and this is a relatively old video, about 4 or 5 years back, but it always gives good lessons about the pupil expansion devices. So in this patient lady was a shallow anterior chamber with a bit of a floppy iris, and I started off with the surgery when the pupil was not too small, but as we went through with the surgery, the pupil came down quite significantly. Today I would use this nice injection called Phenocaine, which is being made by one Indian company, and it contains phenylephrine and lignocaine, and it really works well to give you a good pupil expansion if you have a sudden constriction of the pupil, and it gives you enough time for you to complete the case. And when I put the Malukin's ring, you can see what happened. It caught on to the rhexis edge, so I had to disengage it. So this is one of the risks with these pupil expansion devices. If you have a rhexis in place, and when you try to put these things, because there is a lot of cortex lying around, and sometimes the contrast may not be there, you might catch the rhexis. And I think I have just 1 minute left to finish, but I'll try to close this out in 1 minute. I was able to then remove the nucleus nicely. Let me take you to the end of this nucleus removal, and at this point I was ready to inject the lens. You can just see that as I inject the lens here, I inject the lens. It's a tripod lens. 5 years back, Zeiss used to make these tripod lenses. And I was using a wound-assisted injection, which is really, really wrong to do in such cases. So anytime you have a subluxated cataract, or you're using a pupil expansion device, or you're using a situation where you want more control, it's never a good idea to use a wound-assisted injection. It's always great to go with a hydrophobic acrylic lens, which will unfold slowly. and you go with the nozzle right on the mouth of the capsular axis and let the lens open up inside the bag. That makes the risk almost the least. Now what has happened here is, you can see that this lens opened up in the anterior chamber, only one haptic was into the bag, and the lens size is much bigger. In those days, they were not making Malugins rings of the bigger size which are available today. So this optic of the hydrophilic lens was bigger than the size of the Malugins ring or the pupil which it gave me. So I was trying to get this, somehow into the bag, and we all know that it's so simple to just get these lenses into the bag. You just have to depress on them and they just go into the bag very easily. But you can see it's not going in because it is not going through the Malugins ring. I didn't realize this at that time, and I was wondering why it's not ready to go into the bag, and I was playing around, but see what's happened is that it's caught the Malugins ring off. So anyway, the end of the story was that we had a problem with the Malugins ring, and the Malugins ring got disengaged, and finally I had to explant this lens and get the Malugins ring out, and we had to settle for a secondary lens situation. So this was just a small lesson for you, and I'll stop here.
Thank you very much, Gaurav.
Thanks, Dr. Amar.
That's really very nice. Ladies and gentlemen, I'd like to thank each one of you for coming for this session, the Phaco Nightmare session. And I'd like to thank Ota, Gaurav, Atya, and Suhas also for joining me in this thing. Any doubts, any questions, please feel free to ask me. I'm right here outside. Thank you very much.
It's my glass.